Hi, my name is Anthony Humphreys.
And I'm Dylan Peters, and we're here today to talk to you about the evidence-based approach for the diagnosis and treatment of patellofemoral pain syndrome, of which we will be referring to as PFPS from here on out.
That's right. So below you can see the list of our objectives for this video, but the purpose is to present the current literature regarding the diagnosis of PFPS and then briefly discuss current physical therapy interventions supported by evidence that you'll now be able to use. So before we start, I want you to write down 3 to 5 things regarding what you've seen during your clinical experiences used for the diagnosis and treatment of PFPS.
So before we get into it too much, let's talk about what PFPS really is. The prior school of thought before current literature is that PFPS was anterior knee pain with the exclusion of any intra or extra-articular tibiofemoral pathology, with 3 major contributing factors, those being the malalignment of the lower extremity and the patella, a muscular imbalance of the lower extremity, and overactivity. However, in 2019, the APTA came out with the current practice guidelines regarding PFPS, which supported the following. Measures such as the Q angle, static or dynamic knee valgus, and overpronation of the foot have not been shown to be predictive of PFPS, suggesting that it's more than just a biomechanical or an alignment issue. And while weak proximal hip musculature is a common impairment found in a majority of affected patients, current literature suggests that this weakness is more likely a result of PFPS and not a causative factor.
That's right. So the current school of thought is that PFPS is pain arising from structures within the patellofemoral joint articulation. Most importantly, PFPS remains a diagnosis of exclusion in the knee joint, making it vital to rule out all other pathologies of the knee before considering the diagnosis of PFPS. It's important for each clinician to do a thorough lower quarter screen to rule out more sinister pathologies, and the skill needed to diagnose PFPS isn't in a specific test, but it's in a foundational understanding of pathology and then clinical reasoning. So the current literature outlines a more succinct method for clinicians to diagnose PFPS, and that is in a cluster, and it's as follows. So pain behind and around or around the patella, and reproduction of pain with squatting, stair climbing, prolonged sitting, or other functional activities loading the patellofemoral joint in a flex position. So this pain can present as acute or gradual in its onset, typically felt in the anterior medial knee. And then finally, exclusion of all other conditions that may cause anterior knee pain, including tibiofemoral pathologies.
In terms of age of prevalence that you'll be seeing with patients, really depends upon the context of where you're practicing. For example, if working in a sports clinic, you'll typically see this age of onset be closer between the ages of 12 and 19, whereas if you're working in an outpatient setting, you'll see this age of onset be closer to 50 to 59 years old.
And it's a common injury in both sexes, with women representing about 55% of those that are injured.
Now that we're through with diagnosis, let's talk about some of the interventions that have traditionally been used for the treatment of PFPS that current evidence does not support. Things such as patellofemoral knee orthosis, including braces, sleeves, or straps, biofeedback training, including EMG studies, dry needling, the sole use of manual therapy interventions such as manipulation or mobilization, and modalities of all types.
So the previous course of treatment was similar to a wait and see, where they would strengthen the quadriceps and then avoid activities that provoked pain. But as they've done studies, especially in runners 5 and 8 years out, what they found is that about 70 to 90% of those had recurring symptoms, not only in the previous leg, but also in the contralateral knee. And so to combat that, the current CPG proposes following the ICF model that we're familiar with, where we treat impairments, we focus on function, and then a key point is educating patients on how to approach exercise and activity in the future with proper loading frequency, magnitude, and rest periods.
Now let's briefly discuss what interventions are supported by the evidence for the treatment of PFPS. Literature currently supports 2 interventions for short-term pain relief, with those being patellar taping and foot orthoses when combined with exercise therapy. As always, it's important to remember that these interventions should not be relied upon for long-term pain relief.
And our research supports focusing on exercises of the posterior lateral hip early in the rehab to promote proximal stability and control during loading, which then decreases force at the patellofemoral joint. Then progressing to combine hip and knee exercises to target patient-specific impairments and desired return to function.
And finally, research supports the combined use of all of these exercises as deemed appropriate on a per-patient basis. Now look back at the list you created at the beginning of the video. How many of those things lined up with what the current evidence support? How might you implement some of these diagnostic tools and physical therapy interventions in your current practice? We'd like to take a moment and say thank you for watching our video. And as always, if you have any comments, questions, or concerns, please feel free to reach out.